welcome to Something to Talk About. I'm Linda McNamee. For the next hour, we're going to talk about cardiac neurodevelopment. It's a big word, actually two big words. We're going to find out what they mean shortly. We are not live this evening, so you will not be able to call us, but if you would like to email me with questions or suggestions for future topics, you can always drop me an email at talk@bcattv.org. And as always, I would like to thank the crew for this evening. Jolie Atwood and Liz Gillespie have given up their Wednesday nights along with Colleen Moore. So thank you, ladies, for coming and hanging out at BCAT. And I also want to thank staff members Chris Flaherty and Jen Dodge, who are also here this evening, making sure that us volunteers behave ourselves and not burn down the building. But we know where the fire extinguisher is. It's okay. But last but definitely not least, I want to thank my husband Paul for staying home for Daddy Date Night. Hope homework is not as painful as it was this afternoon. Now, business aside, I would like to introduce my wonderful guest for this evening, Catherine Ullman Shade, who likes to go by Kate, I'm guessing, and you are the Director of Education for the Cardiac Neurodevelopmental Program.
Yes,
and you get paid for every character in your at Boston Children's.
Yeah.
Totally. So thank you very much for joining me this evening. I did not know that cardiac neurodevelopment existed until talking to one of my son's classmates' parents, because second graders probably can't pronounce that word either. Mm-hmm. And they said, Kate would be great for your show. So thank you for coming on. And before we get into tonight's topic, can you tell me a little bit about yourself, where you grew up, how you came to the Burlington/Boston area, and why you decided to get involved in this field?
Sure, yeah. So I definitely didn't expect to end up where I am.
Who does?
Yeah. It's not a direct path. I grew up in Newton, so
so you are kind of
pretty nearby,
okay.
Yeah.
I used to live in Newton before moving to Burlington.
All right. And I went to Tufts University. I have a Master of Education degree, and then I went to Tufts to get a PhD in child development.
Okay, so you were going that route.
Yeah, and my focus was really reading and dyslexia, language and literacy. And after graduating, I was applying to jobs very widely, was increasingly pregnant, which means I was getting increasingly desperate about where to apply for jobs, and ended up at Boston Children's Hospital and Developmental Medicine Center doing academic evaluations, which is something I had some experience in.
Okay.
I expected that to be temporary and then really fell in love with the hospital and with the people there, and then ended up eventually transitioning over to cardiac neurodevelopment, which is just a much more specialized population of kids. So I have background in teaching and curriculum design and academic assessment and teacher training, but now I'm in this role with this very sort of specialized
Now, did you have to
group
go
of kids.
back to school and learn, or is it more like on-the-job training?
No, I mean, really, the bulk of my job, I have to know a lot about how kids learn, about different learning disabilities, and about how the schools work, and then also I need experience in how to teach adults, because I do a lot of training in the community.
Trainer type thing.
Yeah, but I have all that experience, and really what I mostly had to learn about is what distinguishes this population, which is kids who have congenital heart disease and what risks and disabilities and delays are often associated with that. But the bulk of my job is really education oriented.
So what is congenital heart disease?
Sure. So it really describes a range of conditions in which
so there's kind of like a spectrum type thing.
Yeah, in which the heart doesn't develop as it typically would.
Okay, so it's always like a birth defect kind of
thing?
It's
a kind
so
of...
it's nothing like develops in your teens or...
No, there are definitely heart problems that can develop later on, especially like having to do with the rhythm of the heart, like arrhythmias can develop later on, but and other problems too, but congenital heart disease is a birth defect.
A birth defect.
Yeah, and it occurs in about 1 in 100 births. And it ranges from really mild to really severe. So, there's many different permutations. So in the really mild end might just be like, a little hole that might even resolve on its own, might not require any intervention. And then...
And what about something like arrhythmia? Is that considered at birth?
That's
because
not...
like my child was born with a heart murmur.
Oh, yeah. So that's not the type
That's something
of thing
different.
that we work with. Our program
so
really...
like a physical issue with the heart?
Yeah, so, we really deal with kids who have complex congenital heart disease. So congenital heart disease in general affects like 1 in 100 kids. And our program works with those kids who have critical congenital heart disease. So really they need an intervention in order to survive. Which is a smaller percentage of that overall number.
How are these issues diagnosed? I mean, is there like an in utero test? Is it a genetic thing? Or how do you figure out if your child may or may not be one of the 1 in 100?
Yeah, so most of the time, well, not most of the time, I guess 30 to 40% of our patients here in Boston are diagnosed in utero, usually at the 20-week ultrasound, the anatomy scan, usually, because these are pretty severe heart defects that we work with. And so it's really a major difference in the heart. And so generally it's picked up at the 20-week ultrasound, and then the person would be sent on for more imaging and more testing. Sometimes it's not diagnosed till after birth when the child usually isn't doing well. Or, in some of the early physical exams, they detect a difference in their heart. And occasionally it's picked up later, but usually because the child starts to show symptoms.
What are some of the symptoms is it like a jaundice thing? Or
Yeah.
What are the symptoms?
So again, we're really talking about a wide range of conditions, from ones that are not a problem and resolve spontaneously to ones that are immediately life-threatening. So, some of the things to look for are like, rapid shallow breathing, a bluish color, which is called cyanosis. So, talk about blue babies, that's babies who are not getting enough oxygen. And then, symptoms of heart failure, like discoloration of the skin. It's for some of the conditions that we work with, there's no way to miss it, because the baby will die very quickly, honestly, without intervention. Others, the baby can survive, but may just, may be weak, may be extremely lethargic, may not get enough oxygen, have trouble feeding, that sort of thing.
Now, does it tend to, I'm guessing that it happens more in premature babies, but can it also be shown, or can it develop in full-term babies?
So actually, it's not really associated with prematurity. And most babies with congenital heart disease are born full-term. It is also, it can be associated with spontaneous termination. So, so when people have a miscarriage, a lot of times that's because of a heart defect. But when the baby's going to go on to survive, there's no reason to anticipate that they're going to be born preterm. But that said, their brains overall tend to develop, their brains tend to be relatively immature for their gestational age. So a 40-week full-term baby with congenital heart disease may look good, maybe 7.5 pounds, maybe look like a full-term baby, but their brain is immature, and their brain usually looks like it's about 4 weeks less mature. So they might have the brain of like a 36-week-old baby. So that actually means that their brain is at higher risk than you'd expect for a full-term baby.
So that's why there are like developmental issues beyond the physical?
That's one reason. Unfortunately, there's a lot of risks that their brains are exposed to. Do you want me to go into
Sure, why not?
So certainly
this is just a cheat sheet.
Sure. So certainly one of them is that they're born with these immature brains, so their brains are at higher risk of injury. They're not getting enough oxygen generally, and sometimes it really varies according to the defect and how it's treated. But sometimes kids are constantly oxygen deprived. Sometimes they're severely oxygen deprived for a short period of time, and then it's repaired. But oxygen deprivation.
I'm also thinking, if you can in some cases identify it at 20 weeks, the heart's already weaker, so the brain is just not developing as quickly as the rest of the body type.
Yeah, I mean, honestly, we don't know all the reasons why the brain looks immature, but certainly, one idea is that they're getting less oxygen in utero.
Okay.
Also, the kids are at high risk of stroke and seizure compared to typical babies.
Okay.
They undergo surgeries, often which are very long. They might be on bypass, so the heart's actually stopped for a period of time. Okay. And then they're exposed to anesthesia, which is anesthesia is obviously totally necessary, but also is toxic, and that affects the brain too.
Okay.
All those drugs, they can be sedated. They're exposed to all the plastics in the nursery. So you think of all the tubes that are going in and out of their body. Those are toxic too, and we're just exposing the kids to tons and tons of plasticizers.
Never thought of all of that stuff.
Yeah, so there's a lot of risks.
Hopefully they don't have latex allergies.
Right, yeah, and then, often they're sedated for a long period of time. And then they just have these, depending on how long they're hospitalized, they can have these very, very atypical infancies. Okay. So, where we talk about patterns of overstimulation and understimulation. So on the one hand, they're in these rooms, there's bright lights, there's beeping, there's painful sensations, there's new faces, which is all overstimulating, and they might have trouble sleeping. But then on the other hand, they're always in the same room, they're always in the same bed, they may be sedated, so they're not exploring the world the way a typical baby is. So all of these things come together to make kids really at high risk for a wide range of developmental delays and disabilities.
So you had mentioned before the show that after birth, generally a child is diagnosed pretty early that he or she has a pretty significant heart issue. And you said sometimes the first surgery is within 3 or 4 days of birth. Yeah,
it depends.
And then you also said there's 2 surgeries after that?
So it depends on the defect. And sometimes, for most of the kids I see through our program, they do require a surgical intervention, either an open heart surgery or a heart surgery where they're kind of going in through an incision in the side, or a catheterization, which is where they make a little incision in the groin and they send something up through a vein into the heart. But
those veins are really tiny at that age.
Most of the kids we see have had at least one open heart surgery. Many have had multiple. I think what you're referring to is for children who are born with a single ventricle.
That's what we're talking about.
So which is especially hypoplastic left heart syndrome is probably the best known condition. And that constitutes a lot of the kids that we work with. They have, the standard treatment is a series of 3 surgeries. The Norwood, the Glenn, and the Fontan, which the Norwood is a really complex surgery that happens usually the first.
Where do they get these names? Every time you say the Norwood, I'm like, well, there's a Norwood, Massachusetts.
It's the surgeon who invents it. Pretty much always. So the Norwood is, usually in the first few days or the first week. The Glenn is, maybe about 18 months, and the Fontans maybe when they're about 3. And these are considered palliative surgeries that make their circulation much better, much more like typical circulation, but it's not a repair. It's not a fix.
It's kind of like a Band-Aid on a broken arm. It'll work, but it's not,
and it comes along with its own risks too. But it gives a chance to life to kids who would have died not very long ago.
Now, in most of these circumstances, I know it's not all or nothing, but do children that go through these surgeries tend to need additional surgeries later on, or is it good enough to maintain the status quo?
We're still learning about this population. It's a relatively new and young population. And a lot of the major heart centers are setting up new follow-up programs that will just follow people with Fontan circulation. And actually at Boston Children's, there's some people who are trying to set that up now. But the oldest survivors with Fontan circulation are in their early 60s. The vast majority are very young. So, sometimes they eventually require a heart transplant. It is associated, Fontan circulation specifically is associated with liver damage. So people may require a liver transplant down the line. And some of the other risks, we're still learning about. But, for usually if a Fontan doesn't work from a heart perspective, the option then is a transplant.
Wow, And how early do you know, how early a transplant could happen, like when they're
It can happen in
or?
infancy.
Okay.
Yeah.
Oh, so it could happen really young. It's not
Yeah.
necessarily. Okay.
Yeah.
And I realize that there isn't an all or nothing thing.
No, and this
There's
is
so many different shades of gray.
yeah, and this is hypoplastic left heart syndrome is really one of the most severe types of
Okay.
heart lesion. These are people who would not have survived before, like,
Okay.
just a few decades ago for the most part, and now many to most are surviving. So that's
Great.
really miraculous.
Yay.
Yeah, but then and then we have a lot of other kids with different types of lesions that don't require that 3-stage surgery.
So we're talking about the brain is slower to develop.
Yeah.
And there's either overstimulation or understimulation. And then what happens? I mean, how long do these children have to stay in the hospital? And then when they get home, I mean, if your child has this condition, will they be late to crawl, late to talk, late to do all these normal baby things? And what do you do to help them catch up?
So again, so there's variation. I'd say for in the best case scenarios, there can be a surgery and maybe the child goes home within a couple weeks, and that's great. And then there's other kids who have much more complex early courses, and they may be in the hospital for a year. And obviously those have very different outcomes. But generally, we see complex congenital heart disease associated with different types of deficits and delays at different stages of development. So in infancy, there's often problems with self-regulation, and so feeding is really hard. Sleeping is often disruptive. Kids have trouble self-soothing, and then usually their milestones are delayed, especially their motor milestones. So they'll be late to sit, to roll over, to crawl, to walk, all those things. Then moving on into like sort of toddlers and preschool, usually language is very often delayed. Feeding often remains really hard, and then behavior can become an issue.
Yeah.
I mean, with issue of
it's not bad enough you have the terrible 2s and the torrential 3s, then
So and then anxiety often becomes increasingly problematic.
Really?
Yeah. So, again, these are kids whose brains are vulnerable, and then also they've experienced often traumas. So we see a lot of anxiety, both in parents and children, and that becomes increasingly prominent during the childhood years. Learning issues start to surface during middle childhood.
If a child, let's go back to like infant and toddler. If a child has been diagnosed with congenital heart disease, does that by default automatically send their case over to early intervention, or do you just wait to see what happens and then?
Yeah. So we definitely advocate seeking intervention, even if there hasn't been a problem yet. So when our kids, from our program, the Cardiac Neurodevelopmental Program, when kids are discharged from the hospital initially, one of our psychologists, Sam Butler, who works on the inpatient floor, she'll do an evaluation and make recommendations, and the recommendations always include going to early intervention for the kids because they have enough risk factors they should qualify regardless. And the vast majority of kids with complex congenital heart disease will show some sort of delays, especially motor delays, just because of the scars and being kept on their back for a certain amount of time, they just tend to show motor delays. And then then we recommend continual surveillance and monitoring to catch early any problems that might emerge, and definitely don't want to have just a wait and see attitude, because unfortunately then you can really miss your moment for intervening effectively.
Especially when they're so young. I mean, their brains are like sponges trying to absorb stuff. So
so those first years are so important.
Now, I don't know if you can answer this, but how significant would those gross motor skills be delayed? Would these children necessarily be confined to a wheelchair, or is it just that they are slower to develop, so they don't crawl as soon?
Sure. Most kids, it's just a delay, so it's just slower, and and then a lot of them catch up, or they'll maybe they'll just not be a great athlete, but they're fine. They can walk, they can run. Some of the kids who have more severe brain damage or who maybe have syndromes associated with congenital heart disease might be much more impaired. And, there certainly are some kids who use a wheelchair, but that's not the typical profile.
Okay. Now, we mentioned anxiety. Do these kids also have some kind of therapy automatically assigned to them? Could that anxiety be confused, I guess, for ADHD or for, I don't know, bipolar or just any of these other developmental issues or these other...
Well, I think, what you're asking really highlights the need for an expert to evaluate kids who have any risk of the sort of neurodevelopmental delay. And actually the American Heart Association, the AHA, recommends that kids who have congenital heart disease be undergo surveillance and testing at specified time periods. And they actually recommend a protocol of recommended tests to use. And the idea there is that we can catch these emerging problems at kind of key transition points in the child's life and distinguish between those diagnoses that may be difficult to distinguish among. And and the suggestion would be that they'd be evaluated by someone who really has expertise in congenital heart disease, so can understands what the risks are and can distinguish between those different diagnoses that may have some similar features.
Because I'm just thinking, when a child is so young, he or she just doesn't have the language skills to explain what's going on. So, and right now, it's just like listening to my kids' teachers. There's so many different things that children are struggling with, whether it's autism or ADHD or just behavioral or developmental delays or genetic issues. So how do you map that out? And could a child with congenital heart disease also have autism? Is there a higher risk of autism or... I don't know.
So they're at risk of there being pretty widespread disruption in the brain, which certainly doesn't happen to every kid with congenital heart disease. Some look great, have really no discernible neurodevelopmental problems, but they're at risk. And so really anything that comes from, the results from a brain difference, they're at risk for. So they have, there's really high rates of ADHD in this population, very high rates of problems with executive functioning. Visual spatial skills are often impaired. And then social skills are often impaired. There seems to be a higher rate of autism, although that's a little bit up for debate, but there certainly are higher rates of social problems that may or may not quite reach the threshold of autism. But these, just because, congenital heart disease is a physical medical diagnosis, but there absolutely can be behavioral, psychological, psychiatric diagnoses that happen alongside with.
Now there are, we mentioned surgeries to correct the situation. Are there other pharmaceutical solutions or treatments or medical, is there like a pharmaceutical path to go on?
For congenital heart disease?
For congenital heart disease to help a patient.
Sure. So, a lot of the kids are on a range of medications. I'm not a physician. I don't know everything. But, for the most part, when there's a real major malformation of the heart, it needs to be surgically repaired. It can't be, you can't just be medicated. But, a lot of kids end up on diuretics or that aren't aspirin and a whole range of other possible medications that I don't know that much about.
Now, back in the beginning of the show, you mentioned that your goal is to educate the educator. So what educator, what is your who is your target audience? And what do you tell them?
So that's a good question. So honestly, I think everyone should know about congenital heart disease.
Let's
because
go that route.
It's not, it's actually pretty common. We're talking 1 in 100 kids. That's a little less common than autism. It's more common than Down syndrome. People don't know about it, and it's affecting kids in everyone's community and every school, and in the workplace, and people just don't know about it. So just as a baseline, I just want to raise awareness. But I have, since I'm an educator, I often work especially in schools. I'll often go out to the school
Now, do you focus like on the preschool level or elementary or just
really, right
everywhere?
now I'm focusing on schools where we have a patient who's a student and go out usually at their invitation to speak to whoever will listen in the school. So sometimes
Who
that's
wants
just
to talk to me?
yeah. So sometimes it's just a team immediately surrounding the child. Sometimes it's a much larger group. And help them understand a little bit more about what congenital heart disease is, how it affects learning, what are the common deficits that we see, and then how can we help in the classroom and try to give teachers really practical strategies for how to address these common learning challenges. And try to apply it both to the individual child, if there is a child that I'm going out for, but also just more broadly, because there's going to be other kids who come through these classrooms for sure. And I want to help the teachers feel empowered and prepared to meet the needs of all of those kids.
So what are some of the examples? Can you give me like an example of what are some of the things to look for?
Yeah, so I mean, a lot of the things that tend to be most difficult.
Not to put you on the spot.
No, not at all.
I'm going to.
So I mean, writing is often extremely hard for these kids. And
is it just writing challenge? But I also remember you mentioning like you originally wanted to study dyslexia.
Yeah. So there hasn't been any research yet showing that there's higher rates of dyslexia.
Okay.
Totally anecdotally myself, I feel like there might be, but I don't have any evidence for that
There's
yet.
no proof.
Yeah, no, we haven't done a study of it yet. But the thing
because it's just the gross motor skills
Well, it's actually so writing is tricky. A lot of stuff comes together for kids. For many kids with congenital heart disease, that makes writing really hard. So yes, so fine motor is one thing.
Some kids don't like to write anyway.
Right. So like fine motor is really hard. A lot of times visual spatial skills are hard. So kids have trouble just like organizing information on the page. They may have trouble with just things like word spacing and margins, that sort of thing. But then also executive functioning skills tend to be challenged for many kids in this population. So that includes things like planning, like organizing and prioritizing ideas. So if you're telling a story or explaining an idea, you need to be able to organize and structure and prioritize those thoughts, and that can be really hard too. And then the rate of writing is often impaired, like the motor output is often impaired. So it's a lot of things that come together in the task of writing that can just make it really, really hard for a lot of the kids that we work with.
So the kids tend to have like IEPs and have assistance with this?
It's not everybody.
Is it just like in a regular classroom environment? How do you, is it like a recognition that, oh, this child has an issue, or is it more of a solution-based, oh, this child has an issue, so I will?
Yeah, it varies a lot. Since, education is under local control for the most part, there's a lot of differences from district to district, and there's also tons of differences from kid to kid. So some of the kids I work with are real cognitively totally intact. Their intelligence is totally within or above the average range. They may just have some really subtle things that I just want to help the school understand. And then some of the kids I work with are really have some limitations in their learning, and maybe in a substantially separate class that's just for kids with intellectual disability. They may have physical limitations or autism. So there's just such wide variation. Certainly people with congenital heart disease are on IEPs more often than other kids, and they're in substantially separate classrooms more often. They're more often retained in a grade, but it's not everybody. And there are probably kids that should be on IEPs that aren't. But there are also
goes for kids who aren't.
But then there are also kids that don't need it, that are really totally fine. They tend not to be the kids that come to see us, but they're out there who are doing great and are totally fine despite the odds.
Now, in addition to assistance in the schools, do extracurricular programs like, again, I'm probably picking bad examples, but like the Lego club or the chess club or the art club, I mean, would these benefit a child because it's extra socialization and socialization has an issue, or should parents focus more on the fine and gross motor skills?
I mean, I am all for supporting the whole child.
So they probably won't go out for the basketball team, but
well, some of them do. We have some patients who are on varsity sports teams, who run marathons. So there's really variation, and some people are just doing remarkably well.
Wow.
People often think I'm going to be solely focused on academics because that's what I'm assessing, but not at all. Like, I really want to see kids thriving as a whole child, and being engaged in their communities, doing recreational activities, making friends. Last year we asked parents how and when is your child thriving. We asked them to submit pictures of their children when they're thriving, and then statements.
Okay.
And what was so striking, and the kids varied enormously in their ability, but the themes that emerged were they were most often thriving when they're out with their community and when they're outside in nature. And so as much as possible, I try to get kids.
Okay.
Get kids out.
Well, playing in the dirt's supposed to be good for you.
Yeah, unless you've had a transplant. But yes.
Oh, all right.
But yeah, I really support getting kids engaged with their peers and out in their communities as much as possible.
Now, I had another question, and it totally escaped me. Tell me more while I think of my next question. Support groups.
Yeah.
So if a family has a child that has been diagnosed with a congenital heart defect, what resources are available to them? Because, I remember after my first child was born, I'm very grateful that she was healthy, or she is healthy. But becoming a parent for the first time is incredibly overwhelming. And then if you find out that your child's going to need open heart surgery, I mean, mind blown. What are there support systems out there, and what are they, and how do people seek them out?
Sure. I mean, unfortunately, I don't have a list with me, but there's wonderful parent support groups. Some of the the big ones, Mended Little Hearts is a big one. There's a Boston branch that's that's very supportive. Sisters by Heart is another. Okay. There's a bunch more. And there's both, in-person events people can go to, and then lots and lots of online communities that people can join that I think are really supportive. Our program is trying to do more with supporting parents, both, prenatally and then after the birth. So we try to track the parent's stress level, refer them to resources as needed. We are starting a mindfulness program for mothers whose babies have been diagnosed prenatally to try to reduce their stress. And then we also offer opportunities where parents can connect to each other. So we have these days, sort of recreational days for the kids, but also chances for parents to connect. So we're doing an event at a therapeutic horseback riding farm in May. Fun. We did one last year too, where the kids get to ride and groom horses, and then the parents get to talk and connect. We also have a family symposium every year where parents can sign up, professionals come too, and there's a whole day of learning about cardiac neurodevelopment, but also opportunities for parents to connect and talk about different areas of interest. It's a family
thing, so does that mean the kids are also involved? Or?
No, not yet. We'd love
I wasn't sure if there was a baby.
Family is in not just professionals, because there's a lot of professional symposia talking about these issues, but we want to open this up to parents and professionals to come together. So we're trying to do more, but really a lot of that need is met by these wonderful community groups that are run by parents for parents.
Now, I'm also wondering, I mean, it's got to be pretty traumatic for the kid knowing that he or she is different. And I actually heard about a friend whose child went to a birthday party at a swim school and saw another child with a scar on his chest, and they're like, you have one too?
That's really sweet.
So, I mean, it just kind of bonded that. So I'm wondering, kids tend to gather around like-minded kids. Are there children's organizations or a child support group or an adolescent support group? I mean...
So again, we're trying to do more ourselves, but there's a,
Okay.
there are things out there. I think Mended Little Hearts has teen events.
Oh, okay.
I believe. Also, there's camps. So there's disease-specific camps,
Oh,
which are
okay.
wonderful opportunities. So
Okay.
one that one of my colleagues runs, Naomi Gothier, is called Camp Meridian. It's in the White Mountains. It's in October. It's a sleepaway camp. A really wonderful sleepaway
fun.
camp. That's a fabulous
It's
opportunity.
in October. Is it just like a weekend thing?
It's a
or-
long weekend. Yep, I think it's
Okay.
I think it's Columbus Day weekend.
Okay.
And then we're actually starting this summer for the first time a day camp.
Ooh,
Just going to
fun.
be 1 week over the summer.
Okay.
It's going to be horseback riding, and so that'll be for kids. I think we're going to do 8 to 14. That'll be an
Okay.
opportunity for them to connect to, and we're hoping to do more. We're kind of easing into this.
Okay. Now, with all of these outreach and
Yeah.
the camps and everything, do you have like a list of partnerships that you have or that you want to see happen?
With
To-
other sort of community
with
groups or-
either other like the horseback riding. Oh, we
Yeah.
partner with this therapeutic riding company or
Yeah,
I don't-
most of what we do, honestly, is within the hospital.
Okay.
And then we have connections with other.
well, children's is pretty big
Yeah.
anyway, so
And then we work closely with the cardiac neurodevelopmental programs in other major hospitals
okay.
around the country and then somewhat
Are
internationally.
there a lot of cardiac neurodevelopmental?
I should know the number, but I don't.
Okay.
I'd say there's.
Like big cities, or are they? Like,
Yeah,
okay.
well, primarily in big cities. I would guess there's dozens, but I don't know the exact number.
Okay.
It's a young field. The whole field
okay.
of cardiac neurodevelopment is only about 10 or 11 years old.
Okay.
But the programs have really proliferated because there's such a need. Because there's
cool.
this
Yeah.
there's this new population.
Now, are you involved in the research at all?
A
about-
little bit.
Okay.
But there's a research wing of my program, and
Okay.
I'm involved a little bit, but more I'm involved in clinical work and intervention and outreach. But we have David Bellinger, Johanna Calderon lead our research department, and they're constantly doing research. And then we also have a registry of data about all our patients that we can. So
Okay.
it's and actually, it's able to be pooled with registries that are at most of the other major cardiac neurodevelopmental programs, so it can do larger studies to learn more about this population. Because again,
okay.
it's just such a new
It is really new.
group
yeah.
that we're still just asking and answering basic questions about them.
Now, we mentioned that you do like a trainer in schools.
Yeah.
Do you ever reach out to like community groups like libraries
Yeah.
or church groups or something to educate them? Because it's like, okay, if these kids thrive in the outdoors, well, maybe some of the outdoor organizations need to know, because a lot of the organizations are volunteer run.
Right.
And the leaders don't necessarily have the educational or the developmental background. So do you work with them at all? And
I
what do you
haven't,
tell
but I'd
them?
be very open to it.
Okay.
Yeah, no, I haven't yet. I mean, I've gone out to early intervention, regional leaders, and other than that, primarily schools and parents. But I'm very open to talking to anyone who wants to
I'm
learn
just
more
wondering,
about
it's
it.
like,
Yeah,
okay, there's so much to learn, and we are only scratching the surface as well.
yeah.
So I'm also kind of looking at my notes. Does an individual ever graduate from all of these treatment options?
Sure.
Or are they always, oh, gotta go see my I forgot it already. Neurodevelopmental
Yeah.
specialist on Tuesday. Or
Yeah. So we generally, when I say we, really the American Heart Association recommends monitoring development and monitoring function over the course of childhood and into early adulthood.
Okay.
At that point, we would try to transition care over to adult providers and specifically to an adult congenital heart disease specialist.
Okay.
Depending on the person's diagnosis and the severity of their heart disease, there could be a recommendation for much more involved follow-up care. Unfortunately, a lot of adults are lost to follow-up, and they don't come back until there's really a problem. So they're, they should continue to see
overstimulation over the past 18 years. I don't want to see another doctor.
Yeah, but there, unfortunately, there are problems that can emerge, and some of them we're really only just learning about. So people should continue to see their cardiologists, and especially an adult congenital heart disease specialist, as regularly as needed. And some people, like anyone with Fontan circulation, should usually be followed for their liver and endocrine, and there's a lot of other issues that can emerge, so they should be followed pretty closely.
So I'm also wondering about like somebody with the congenital heart defect that they might end up wanting to play sports. So do they just get clearance from their doctor, or do they have to get more frequent checkups?
Yeah.
Or
most of the kids we work with have no physical restrictions. They can play whatever as long as they feel good. It's fine. And certainly have
running a marathon just doesn't seem to be high on my list of priorities.
Yeah, but I know people who do it with congenital heart disease. So and who play sports competitively. It just really depends. And then there are some patients who are much sicker who can't, who have to have low endurance, or who have exercise restrictions. But that's really a minority. Most people can do whatever feels good. And actually the recommendation is that they should exercise to stay healthy for the vast majority of patients. I was going to say, is there like
a suggestion of, diet adjustment? I mean, is that like a requirement, or
depending? So it's a little bit of a complicated question. So the young kids usually may have really different nutritional needs than typical babies and toddlers. So they're often monitored by by a whole nutritional and feeding team, making sure that they're getting.
Is it because of the feeding issue, or is it
and then how about they're expending a lot of energy, if their heart's working inefficiently, and they need like a sort of slightly different nutritional balance. Honestly, I don't know the details. And often a very high calorie intake.
Gee, I wish I had that problem.
Right?
Here, you have to have more calories a day.
As people get older, I'd say like most of the people I work with have in a pretty average diet, just probably general recommendation, try to eat healthily, but that's like same as everyone. Occasionally there's people who have like, they can't have salt, or they have fluid restrictions depending on what the situation is with their heart, but that's not most patients. That's for people who are sicker or at higher risk for some reason.
I just wasn't sure where that line fell.
Yeah, I mean, really, it's up to the cardiologist to figure out what's safe for each individual. But I'd say most children, young adults that we see, they don't have exercise restrictions. They can eat whatever they want. They should probably eat healthily, but like we all should.
Yeah, we all should. Yeah. But we don't.
Right.
I know this is a loaded question, but every time you talk about treatments and hospitalizations and surgeries, how does insurance fit in with this whole picture?
Sure.
I mean, are insurance companies generally helpful, or are they just like, sorry, pre-existing condition, go away?
Yeah. Well, so since I'm an educator, I can never bill to insurance. So I am sort of in this blessed position of not knowing as much about insurance as many of my colleagues. Most of the services that we provide, certainly the medical services that the cardiologists provide, and then also the behavioral health services that my psychologists colleagues provide, are covered by insurance. It's usually not an issue to get coverage. And education services are never covered. And, most of the patients we see have at least primary insurance, often primary and secondary insurance, and it's not usually an issue. I think just because they're sick enough, it's so clear that they need the help. Yeah, it's usually pretty easy. And unfortunately, I don't know how that varies in different parts of the country. I don't know if there's differences.
I don't think anybody knows that right now.
Probably someone knows better than I do, but yeah.
What else do you want to talk about? Where do you see the condition or its treatment in, you mentioned that it's only about 10 or 11 years old.
Yeah.
Where do you see your job in 5 years?
Sure. So, the last few decades have seen really remarkable advances in the treatment of congenital heart disease from a medical standpoint. So, conditions that were almost 100% fatal a few decades ago, now a majority of kids are surviving. And so as a field, there's really been a shift away from getting kids to survive towards making sure that we maintain a high quality of life. And, often people talk about thriving, not just surviving. So I hope that shift will continue, that really more cardiologists and cardiac surgeons are thinking about the long run, not just thinking about getting the kid to reach their first birthday. I think there's increasing recognition that we should try to prevent or mitigate potential injury to the brain. If at all possible, because we're so aware now of the risk.
I'm wondering how would that look?
So people are this is a really new area of research. And I mean, we don't know in many ways, but certainly in the operating room, there's many things that the surgeon and the anesthesiologist can adjust, and the perfusionist, which is the person that sort of gets oxygen to the brain during the surgery. And there's a lot of research going on right now trying to figure out which precise approach leads to the least injury in the brain and the lowest risk of complications afterwards. So things like, do you induce hypothermia before the surgery? And if so, like, how quickly, how cold? Do you stop the heart? Do you go on bypass? So there's all these questions. And then, like, how do you send, like, supplemental oxygen to the brain during the surgery? If so, exactly how and how much, and what should be the, how exactly should the blood be composed? So there's all these really complex questions that may dramatically affect how the brain reacts to surgeries, and people are actively trying to figure out, is there a way to help protect the baby? Also things like what drugs are used for the anesthesia.
I was just about to ask if they were,
and looking at which ones maybe
are less toxic.
Yeah, exactly. And are there even ones that could be protective of the brain? And then things like, looking prenatally, like, in some conditions, does it helpful to give the mother oxygen while she's still carrying the baby, or help the mother experience less stress, or there's and for most of these things we don't know, but there's active research to try to figure out how can we help protect the brains of these babies so that they're less at risk, and then potentially prevent some of these problems that we know are really common.
I don't remember if I asked you, is there a hereditary component of congenital heart disease?
Yeah. So certainly if someone has
to, like, look for, the mom has it, or the mom's sister,
Yeah, so there definitely is. Right now, genetics is really a moving target because it's evolving so quickly. Right now, about half of cases of congenital heart disease can be explained genetically. The other half are some, like, as yet unidentified combination of environmental and genetic factors, but no one knows what. For that half, sometimes it clearly comes from a parent and was inherited, and sometimes it's just a spontaneous mutation in that child. And then
in your experience, is there, like, a gender difference? Does it tend to be more male?
That's
female,
a good question, and not that I know of, but I'm not sure, actually. But not in my experience, and I don't believe so. I don't think I've ever heard that. There are certain well-recognized syndromes that are widely, that are connected to congenital heart disease. So, like, Noonan syndrome, Down syndrome, 22q11 deletion syndrome. So it's so it has a lot of different things associated with it. So there's, certainly there's heart disease. There can be mild to moderate cognitive differences. There's some sort of distinctive facial features. Often, like,
so the heart condition would come first, or because there's this genetic mutation, it would lead to
the heart disease is one of the manifestations. And so, that's
like if a child already had Down syndrome, then he or she would be more likely to develop.
Yeah, but when we talk about to develop, it's all in utero. So
Yes.
like, yeah,
Okay.
yeah. But
more likely
kids,
to be born with.
yeah. So like kids with Down syndrome
Okay.
very often have heart defects. Kids
Okay.
with Noonan syndrome, 22q11 deletion syndrome, charge syndrome. There's a whole list of them.
A bunch
where,
of syndromes.
Yeah, where they very often have
Wow.
heart defects. And so, when a child is born with a heart defect, especially if there's like a sibling or something, or if there's other features that might suggest a syndrome, usually the recommendation is for pretty complete genetic testing to try to figure out what's going on.
Is the genetic testing before or after birth?
It
Or
could
both,
be.
or just whenever?
Yeah, so you can do some sorts of genetic testing before birth. Sometimes people want to know if their child, is likely to be born with a syndrome. And then after birth, parents often will choose it too. It can affect treatment. It can help to anticipate potential other problems.
Okay.
And then certainly can help people understand if other people in the family may be affected that you might not know about, if future children might be affected, if that child were to, grow up and have children, if they would be affected.
Okay.
And you might be able to identify other people in the family who might be at risk for something that they don't even know about.
Okay.
So it's generally recommended, although it still can be quite a hard decision for the parents sometimes to get genetic testing.
Well, that's also why we have the whole support system to come in.
Yeah. But yeah, it's it can be scary, and for some parents it seems a lot scarier to have it be like a syndrome than to just have.
Well, anytime your child isn't perfect, it's kind of scary.
Yeah.
Now, again, I know there's a wide range of spectrum. There's a wide spectrum. Do some of these children that are developmentally delayed, like in the first 5 years, do they eventually catch up with all of these other interventions, or are they pretty much destined to be behind the 8 ball for the rest of their lives?
I think there's this is how
I know.
There's again there's pretty wide variation.
Okay.
Usually after about after about 18 months, cognitive testing, like intelligence testing, tends to be somewhat consistent and is at least predictive of future scores. So, in sort of, if a child looks totally fine at 5, 6, 7, they're likely to continue to look quite good. If a child has intellectual disability at 5, 6, 7, that's unlikely to change. But there certainly can be developments. Certainly any sort of when there's targeted intervention and a responsive, caring caregiver.
Because like the whole anxiety thing, will eventually the child learn to, coping mechanisms?
Yeah, so kids are really, the kids are really malleable and they can learn. Yeah, so absolutely, like with appropriate treatment, something like anxiety can get a whole lot better. Kids can develop much stronger social skills. There are some issues that often do emerge in later childhood and adolescence, but again, with appropriate intervention for a lot of kids, those can be lessened or really kind of overcome.
What are some of these?
So, as schoolwork becomes more abstract and as it requires more organization and independence and longer writing and self-expression, a lot of kids start to struggle more. So, for kids, some kids who don't experience any problems up through like 4th grade-ish will start to struggle a little in school, 5th, 6th, 7th grade. And then, with teenagers, there is also a risk for anxiety and depression, maybe in kids where it hadn't appeared earlier. Kids can get more self-conscious about their bodies. They can get more concerned about their long-term prognosis and their health. And then also there's the risk of risky behavior in adolescence that isn't really an issue earlier. So like compliance with drug regimens starts to be an issue. Kids maybe take risks with like drugs and alcohol that might be particularly damaging with their heart defects. So there are new risks that come along later on. But as long as everything, that's part of why it's suggested that we monitor these kids regularly, and especially at these key transition points. So like, at transition to high school, at transition to middle school, at transition to kindergarten, to just see if the kid's ready for this next step. Are there any emerging issues that might start to be a problem? And then to intervene early and really effectively to try to prevent those problems.
Okay. Now, as the again, we mentioned that the program is fairly new.
Yeah.
As the program gets older, do you anticipate the development of support groups for adolescents, for, high school students, for, transitioning to college or?
Yeah, absolutely. So we, currently we see young people up to age 24, and then we try to transition them into adult programs, and we're trying to expand our transition age program, which is going to be from 12 to 24. We are.
So you still see patients that are up to.
We'll see them up to 24 now. But we're trying to. We're working actively to make that a more robust program, where we're really trying to set them up with a transition program to help them transition to adulthood really comprehensively. We don't see adults beyond that age because we're childhood providers, pediatric psychologists, pediatric neurologists.
And you still go up to 24.
Yeah, what we found is, kids are then going through college or finishing up with public school if they are more limited at age 22, and then they need a couple years to kind of see where things go, and then they're ready to be released.
Developmentally, the brain is fully developed by the time they're 18, 20, or I don't know.
Yeah, so actually people are saying more like 24 to 27, so it even makes sense with that. But it's really, we just found that students tend to need support through age 22, whether they're in college or whether they're still in the public schools. And then need a couple other years just to get themselves sorted out. So we decided to see them up to 24. But then we try to send them on, because we're really not, there are different issues that come along in adulthood, and the providers in our program aren't really equipped to deal with them as effectively as adult providers.
Now, with this older age group, I hate to say old being 20, but do you look for feedback from the patients or from the patients or clients or something about what they need? Or is it,
absolutely. I mean,
you can't exactly ask a 3-year-old, what do you need? What would help you? But,
although we do try to ask younger kids, what, are there things we can try to help you with? What do you notice is hard? So we do try to get that from younger kids too, but certainly with older kids, and especially once people are 18, they've reached the age of majority, they're the patient. And the parent doesn't, everything is addressed to them. The only exception would be if a patient
isn't like another syndrome or something.
If they're not able to care for themselves, the parent may have guardianship. But even so, we try to make it as patient-centered as possible to really focus our efforts on their goals, on their needs, on their visions of themselves. And when we do establish this transition program, that's the goal, is to help young people achieve their own goals, whether it's whether it's going to college and then medical school, or whether it's living in a group home and having some productive work and some friends. Whatever the goals are, we want to help them achieve them.
You know what? We are just about out of time.
All right.
So, I really enjoyed our conversation.
Yeah, thank you.
And didn't mean to keep putting you on the spot.
Not at all.
Fascinating field, and I hope it grows in the direction that you'd like to see it.
Yeah.
And I also want to thank everyone at home for tuning in this evening. I hope you enjoyed our conversation and found it as educational and informative as I have. And check out the website and enjoy this beautiful weather, and I will see you around town. Good night.